Welcome, everyone. I'm Paul Heidenreich, Chair of the California Technology and Assessment Forum panel, and I want to welcome you to this meeting. We have, I think, excellent discussion planned for today. Before we begin, we're going to have each of the members of the panel and then our experts and patient representatives introduce themselves and at the same time provide any conflicts of interest. We take that very seriously. Any panel member with a significant conflict of interest won't be voting on any of our questions today. So I'll begin myself. I'm a cardiologist at Stanford and Palo Alto VA and health services researcher, and I have no conflicts.
Hi, I'm Elizabeth Murphy, and I have no conflicts. I'm an endocrinologist at UCSF and based at San Francisco General Hospital.
Robert Rentschler, I'm a retired medical oncologist, no conflicts of interest.
Rena Fox, I'm a general internist, professor of medicine at UCSF, and no conflicts.
Bob Collier, I'm a very long-time patient advocate, and I have no conflicts.
Alex Smith, I'm in geriatrics and palliative care at UCSF, and I have no conflicts.
Ralph Brindis, cardiologist, UCSF, no conflicts.
Annetta Langer-Gould, neurologist at Kaiser Permanente, Southern California. I have no conflicts of interest.
Richard Seiden, I'm a patient advocate. I have psoriatic arthritis, and I have taken one of the medications under discussion, so I will not be voting.
Good morning, I'm Jeffrey Hotch. I'm a professor of health economics at the University of California at Davis, and I have no conflicts of interest.
Good morning, I'm Kimberly Gregory. I'm a maternal fetal medicine specialist at Cedars-Sinai Medical Center, and I have no conflicts of interest.
Felicia Cohn, I'm a bioethicist with Kaiser Permanente in Orange County, and I have no conflicts of interest.
Good morning, Neil Kohatsu. I'm a physician researcher at UC Davis Health, no conflicts of interest.
My name is Sei Lee. I'm at UCSF. I'm a geriatrician and palliative care doc, and no conflicts.
Rita Redberg, I'm a cardiologist at UCSF, and I have no conflicts.
Thank you, panel. And now we'll begin with our expert panel and patient representatives.
Andrew Konkoff, Chief Value Medical Officer for United Rheumatology. I'm a rheumatologist, although I've accepted speaking fees and honoraria from pharmaceutical companies that it's not relevant to the topic at hand, so I have no conflicts.
Chris Phillips, I'm a full-time private practice rheumatologist, Western Kentucky, representing American College of Rheumatology. I chair their insurance subcommittee. I have had several patients in trials for upadacitinib and have been a clinical investigator for them.
My name is Peggy Ailing. I'm an RA patient, and I have no conflicts.
Hi, Julie Eller, Director of Patient-Centered Strategies at the Arthritis Foundation, and I have no conflicts.
Well, thank you, everyone. And I also will ask that anyone giving public comments today also disclose any financial or other potential conflicts with our discussion. So at this point, I would like to introduce Steve Pearson, who is President of the Institute for Clinical and Economic Review, who will go over our program mission and value.
Great. Thank you very much, Paul. Welcome, everybody, to this meeting. Thank you very much in advance to our clinical experts and patient experts. We have a lot to cover today. Why are we here today? We always like to try to frame this in a variety of different ways, and the best way is to start with words from patients. As we talked to them, we heard about the severity, the lifelong burden of rheumatoid arthritis. And here's one quote from a patient. In the weeks leading up to my diagnosis of RA, I had so much joint pain and fatigue that I could barely write, buckle my seatbelt, or do laundry. I cycled through countless treatments before I finally found one that worked, but even still, living with this disease will always be a challenge. Though my physical symptoms have improved, I struggle with anxiety and depression, worried about whether I can play with my grandson or if I'll feel well enough to leave the house to see my friends. And for me, the physical pain isn't even the worst part of this disease, but the emotional toll it has on my life and on my loved ones. So there's a real, still, if you will, unmet need, a strong one for patients who struggle with a chronic and severe condition. We're also here because of what's been happening with innovation, pricing, and coverage for the whole class of autoimmune drugs that we'll be talking about today. To be clear, innovation has completely revolutionized the treatment of patients with RA over the past 20 years. The types of treatments available, the benefits that can be seen are really, really dramatic. And during that phase, we have seen innovation create not just multiple drugs using one mechanism of action, but a new burgeoning class, different classes of drugs, which use different, sometimes overlapping to a certain extent because they all involve the autoimmune pathway, but really different types of drugs, which give patients and doctors an increasing palette from which to choose drugs to help patients in different ways. Interestingly, it still remains stubbornly difficult to identify clinical characteristics or biomarkers that will help really pinpoint which of the many available drugs will be best to start out with, at least for most patients. With limited exceptions that we'll talk about today, it's still a bit of an art in terms of which drugs are used and in which sequence. The other thing that's happening is that over the past 20 years, the aggregate cost of autoimmune drugs has been climbing ever more rapidly. A few statistics on that. The aggregate cost of autoimmune drugs as a group are one of the highest in the United States. They are equal to that of all cancer drugs combined. From 2012 to 2016, spending on autoimmune drugs doubled among commercially insured patients in the United States. From 2015 to 2018, the number of prescriptions for autoimmune drugs went up by 55% in 3 years. And what that means is that payers are struggling to view how to control the cost while benefiting from the clinical advances that these drugs can offer. And so what our system does to try to make that balance happen is to use formularies. Formularies have really been dominated by the issue of rebates, which have led to some drugs getting preferential status across all the different indications in autoimmune treatments, even if they might not be clinically the best in that particular indication. So we have issues around what's called bundling of rebates that has really driven a lot of formulary placement. We'll talk a fair amount this afternoon about how another way to try to control costs while balancing other aspects has been to switch patients. Even year to year, we've heard stories of patients who stay with the same insurer, and year one, their preferred drug is X, and suddenly next year it's drug Y. It can even go back to drug X the year after that. Other patients who change insurers, change employers, change insurers, find that they're often asked to switch back to a drug that they might have tried before, or to go through a process of trying to explain why that is not clinically appropriate for them. Meanwhile, the out-of-pocket costs for patients have also gone up, and as rebates have come to dominate the autoimmune area with very steep net gross to net gaps, patients' out-of-pockets remain linked to the list price, which means that their out-of-pockets have gone up. They frequently hit the out-of-pocket max. They frequently need copay coupons to help afford these drugs. So our system has created a complex web that many people feel is working for absolutely nobody. And yet, we do have innovation, and we need to figure out how to continue to bring that into the system, to incentivize it in the right way, and to try to do it in a way that's sustainable and fair. So that's just a small goal for us today. You've met the members of the California Technology Assessment Forum. Let me tell you just a few words about ICER, which is, in a sense, the academic secretariat and the convening organization. So we are a nonprofit, an independent nonprofit research organization. Our funding is shown here, which we keep updated on our website. You'll notice the big blue chunk, which comes from nonprofit foundations, which is about 4 or 5 foundations. The primary funder within that group is the Laura and John Arnold Foundation. We also take about 20% of our funding, as you'll see, from health plans and provider groups and manufacturers. That's to support a separate policy summit and evidence dialogue function, and is not used to support the research that goes into the reports that you will be discussing today. The report itself, which serves as, in a sense, the background and the structure for the conversation, started about 7.5 months ago in a phase that we call scoping, where we go out to the manufacturers and to patients and patient groups and clinical experts and really try to understand, seeing that new drugs are coming in expected soon, what do we need to know about these drugs? What matters to patients about their treatments? What looks good? What matters to them and their families? And this sometimes is in conflict with what the evidence has in terms of the needs of patients to measure outcomes that matter to them. It may not be in the clinical evidence, so we need to start to wrestle with that issue as early as possible. Then we do go off and do an independent systematic review of the literature, working with our external academic colleagues at UCSF in this case. We do that, and then we also do cost-effectiveness modeling to help get a look at the long-term cost-effectiveness. The report itself goes through several cycles of public comment and revision, and then we also are benefiting from expert reviewers, two of whom are on our panel with us today, Dr. Konkoff and Dr. Phillips, and also Dr. Worthing, who's chair of the American College of Rheumatology Committee on Government Affairs, and Matt Stevenson, who's a professor of health technology assessment in England. So the report is structured in a way to hopefully support the conversation that we need to have if we all really believe that this is our goal, which I think we do. We want fair pricing linked to fair access in a health system that produces ongoing future innovation. Now, to get there, we think that decision-making today needs to think about two basic elements: the long-term value for money of treatments and the short-term affordability. So within our reports, we structure it this way, and we believe that long-term value for money is a judgment best supported by 4 different considerations. First is a clear look at the evidence on comparative clinical effectiveness. This is usually what's in the clinical trials, but we really are eager to supplement that with information from patient groups, from surveys, whatever we can get to inform that judgment. We do an incremental cost-effectiveness model. We will also talk about other benefits or disadvantages that these treatments can provide to patients and their families that might not be captured in any of the clinical information available, but that is important for payers and others who are thinking about the broader value. The context in which all of this is looked at often has to deal with questions of whether there are other available treatments, how severe and kind of burdensome is the condition, amidst other contextual issues. For short-term affordability, we need to think a little bit about whether, even if it's a good long-term value, will there be short-term budget effects that might put a real strain on budgets and lead to short-term imposition of access restrictions or increases in premiums or out-of-pocket payments that are also very deleterious for patients. So that's the way that we will structure the discussion today. The agenda following this will be a presentation of the evidence. We're very happy again to have patient and clinical experts at the table to help inform that discussion, to serve as a resource to the CTAF. We'll have manufacturer public comments and discussion, then public comments and discussion. There will be lunch, and those of you who are with us here today, lunch will be served just outside here from 11:45 to 12:45. Then we'll come back to do further deliberation and have a vote on specific questions related to the comparative clinical effectiveness and value of the new treatments. And then, as I mentioned, a policy roundtable where we will try to cast our thoughts forward and say, if this is the state that we are in today with the evidence, what does it have to tell us about clinical practice? Where does it need to go? What do we need to do with clinical guidelines or future research? What do we need to do about coverage and pricing to try to hit that 3-part goal that we mentioned before? So we'll do that with final reflections from the CTAF panel and be done by 4 o'clock. Now, we've already had the experts introduce themselves, so I'll just show these slides briefly. But again, with thanks to them and to the patient experts, I can now hand it over to Professor Jeff Tice, Professor of Medicine at UCSF, to start with the evidence review. Jeff?
Thanks, Steve, and thanks to everybody for joining us today. I wanted to acknowledge my collaborators, Naomi Flush and Serena Heron-Smith from ICER, as well as Professor Judith Walsh from UCSF. All of us have no conflicts of interest relevant to this report. We've already heard from Steve a little bit. RA is the most common chronic inflammatory arthritis in adults in the U.S. It affects between 1.3 and 1.8 million Americans. The peak incidence is between the ages of 50 to 60, but it occurs earlier, as we see in the room. It's also more common in women, I think, again, reflected by our patient representatives. They're affected about twice as often as men. There are two major classes of medications: the conventional disease-modifying drugs. The poster child is methotrexate. That's really the standard, though there are a number of other conventional DMARDs. And then the targeted immune modulators, and we're going to talk about one class of them today, the JAK inhibitors. The disease course is one of progressive disability, but thankfully, as Steve alluded to, with the availability of the disease-modifying agents, we no longer see patients progressing to wheelchair-bound status, which used to be the norm for older patients with rheumatoid arthritis. Most of them now preserve joint function. That appears also one of the other disease entities that's associated with rheumatoid arthritis has been an excess of cardiovascular outcomes, heart attacks, and so on, and the disease-modifying agents appear to be reducing those back down to the level of the general population. The TIMs, these targeted immune modulators, have been a huge advance for patients with rheumatoid arthritis. Patients highlight to us, and you heard from Steve's quote, that it can be difficult to diagnose rheumatoid arthritis. There's often a delay. They present differently, and the disease course is different. There's no one typical patient with rheumatoid arthritis. The movement in the field has been towards more aggressive treatment. We think that's in part why we no longer see as much severe joint disability. And the current paradigm is a treat-to-target paradigm, where if patients are not achieving remission or low disease activity by 3 months, then we move on to a new therapy. As you've read in the report, that's sort of the paradigm that we took in this report, which differentiates it from the prior report 2 years ago, the prior ICER report. We got lots of input from patients and patient groups. Steve already reflected on much of this: the insurance requirements, the frustrations with limits on changing therapy when clinicians think it's appropriate, the financial challenges, not only from drug costs, but also from lost time at work for the patients, for their caregivers, and the complexities of care coordination. In addition, there's been frustration about the kinds of outcomes that are typically used in the clinical trials, and they really have been active in promoting more patient-centric measures. And actually, rheumatoid arthritis is one of the disease areas where they've been effective, and you'll see, I'll allude to some of the outcomes, particularly in some of the upadacitinib trials, where the patient-reported outcomes were incorporated not as first-line as primary outcomes, but as important secondary outcomes. And then, again, highlighting that RA is different for each patient, and it's different over time, that there's a waxing and waning, there are flares of the disease, and sometimes our measures that we use to summarize clinical trials don't fully reflect this, because the measures are one point in time and are not integrating the total experience of patients over years of living with the therapy, living with their disease, excuse me. We heard also about challenges with the availability of rheumatologists to care for patients. If we're trying to get them in early, aggressively treat them, we actually need more rheumatologists. People think this is in part why there are delays in diagnosis. And then Steve already alluded to the remarkable rise in the costs for autoimmune diseases and how that particularly impacts the out-of-pocket costs for patients. So I won't belabor that. So again, today we're going to focus on the Janus kinase inhibitors or JAK inhibitors. There are 3 that are FDA approved: upadacitinib, tofacitinib, and baricitinib. One of the remarkable things about these therapies is they're oral compared to many of the other TIMs, which require either subcutaneous injections or intravenous infusions. So a real advantage, and we'll come back to that in the end when considering the overall value of these therapies. And then we're also going to talk a little bit about biosimilars. This is primarily to set up a discussion during the policy roundtable in the afternoon, but want to highlight one biosimilar, Infliximab-dyyb. This is the standard naming format for biosimilars. You have 4 letters added to the name of the reference product. In this case, the reference product is Infliximab or Remicade, which had almost $20 billion in sales worldwide and almost $14 billion in the U.S. in 2018. It has multiple indications: rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and a number of other indications. But again, we're using this not really to focus in on Infliximab-dyyb, but really to use this as an example for a larger discussion about the uptake of biosimilars in the U.S. and why that hasn't been, the story hasn't been like that of generics for small molecule drugs in the United States. So with that, I'm going to turn to the clinical evidence. So our approach, our target population, were patients with moderately to severely active rheumatoid arthritis who didn't respond to previous either conventional DMARD therapy like methotrexate or other C-DMARD therapy. Primary interventions were JAK inhibitors, and the comparisons of interest were head-to-head studies between the JAK inhibitors and other TIMs. In this case, we didn't find any head-to-head trials between the JAK inhibitors, and the only TIM included in randomized trials head-to-head were adalimumab. And then, of course, we're also going to compare them to continued C-DMARD therapy alone. The key outcomes, again, with the treat-to-target paradigm, the target is really disease activity and remission. There are 4 widely accepted measures: the DAS-28, either modified by CRP or ER sedimentation rate levels, or the CDAI or SDAI. There are other measures of treatment response. A standard American College of Rheumatology measures at the 20, 50, or 70. That reflects to the percent of joints that responded to therapy. Radiographic progression clearly is an important outcome. That's what we're trying to prevent, or one of the things we're trying to prevent is long-term joint destruction. This is linked to function, and the HAQ-DI is one of the standard measures of function for patients with rheumatoid arthritis. And then the last 3 I highlighted, these are the outcomes that we heard again and again from patients were really important to them and inadequately captured in much of the data. So pain, ongoing pain, fatigue, and their quality of life, even if they've achieved low disease activity by the disease activity measures, patients are still unhappy with their therapy. They don't feel like they are adequately treated. There was recently a survey sponsored by the Creaky Joints Association and showed that 3/4 of patients were still unsatisfied with their therapy, despite 2/3 of them being on biologic therapy or other TIM therapy. They still had not achieved control of their disease. Productivity loss and healthcare utilization are other important outcomes for patients and their caregivers. There's very little data on the literature there. And, of course, the potential harms of these therapies that are affecting the immune system. So the evidence base for today, we found 19 randomized trials and 3 observational studies that met our inclusion criteria. They were mostly of good quality. They had strong internal validity, but most of them, in keeping with the treat-to-target approach, had allowed for early rescue. So if they weren't responding at 12 to 24 weeks, they were switched to other therapies. So very hard to evaluate the long-term effectiveness of one drug in and of itself. We really just get short-term looks at the potential benefits of therapies. We struggled with different variants of the different measures of disease activity and joint progression. The definitions have evolved over time, and they're not measured at consistent time points, and the same measures are not used across different drug studies. So that's one of the major challenges with our evidence base. In part because of that, we were unable to perform indirect comparisons or a network meta-analysis for the outcomes that would have been most useful to us, the DAS28, either incorporating CRP or ESR, the CDAI and the SDAI. We did have consistent reporting of the ACR outcomes, and I will briefly show the results of that network meta-analysis in a few slides. So we broke this up into two large groups of patients. The first were patients who had mostly not seen TIM before. Many of the trials had inclusion criteria that limited the number of people who'd had prior therapy to 20% or less. Most, it was on the order of 5 to 10% had been on, if they were included at all, no more than 5 or 10% in the trials. And for upadacitinib and tofacitinib, when added to conventional DMARD therapy compared to continuing conventional DMARD therapy, and of course these are patients who've had inadequate responses already on conventional DMARD therapy, we saw significant improvements in all the outcomes that mattered: disease activity and remission, the ACR response, function and reduction in disability and radiographic progression, and quality of life, pain, and fatigue. So clearly better in patients who failed DMARD therapy to switch to one of these two JAK inhibitors. In head-to-head trial with adalimumab, the Select Compare trial, upadacitinib was superior to adalimumab on all of these outcomes, including quality of life, pain, fatigue, and function. But there were no data on return to work or school. And I should say two additional things that aren't on this slide. One, baricitinib was studied, but at a higher dose, a 4 milligram dose, which did not receive FDA approval. So we have no data on baricitinib in this population. In addition, in the trials of tofacitinib, where it was compared head-to-head with adalimumab, the conclusions of both of those trials were that there were no significant differences in the outcomes between tofacitinib and adalimumab. Here's a graphical representation of our network meta-analysis results. I'll see if I can make this a little clearer. Let's see if I'm... what I didn't want to do. Is this going to work? All right. So here what we've done is broken up the response of patients into those who really didn't respond. So less than 20% of their joints responded to therapy. So these are the poor responders versus the best responders. 70 to 100% of the joints responded. And these are the ACR criteria. In the middle, the drugs in blue, and to the left is upadacitinib. Green is tofacitinib, black is adalimumab, and orange is placebo. And you see the placebo group, the majority of patients, more than 70% of patients, essentially didn't respond, whereas those on active therapy, there were much better responses with upadacitinib, a little bit better, though not statistically significantly different from the other TIMs. And then when you get up to the best responders, you see that, again, upadacitinib, you see about 25% of patients had the best response. Adalimumab and tofacitinib are, you see the bars are almost identical in all three, so the results were very, very similar with tofacitinib and adalimumab, and then placebo, of course, had the fewest patients with significant response. Placebo, again, these patients are continuing on conventional DMARD therapy. There are ongoing improvements over time, and it can also reflect some of the natural history, the waxing and waning of joint involvement of disease over time. So this is the only network meta-analysis that we're able to perform. Now we're going to switch gears to patients who've already tried and failed at least one TIM. There's one clinical trial for each of the three JAK inhibitors, upadacitinib, tofacitinib, and baricitinib. Again, the results are very similar. There were significant improvements in disease activity, remission, and the ACR responses compared to continuing to CDMARD therapy alone. And that was true at the time point we think is most important, the 12-week outcome, because again, if you don't achieve at least low disease activity at that point, current guidelines recommend switching to a different therapy. So I went back there, sorry. Let's see. All right, sorry about that. And then there were also significant improvements in function, reductions in disability and radiographic progression, as well as improvements in quality of life, fatigue, and pain. In this area, again, one trial for each drug. There were smaller drugs, a couple of 100 patients versus 600 or more patients and multiple studies in the TIM-naive population. So there's a little more uncertainty about the results, but pretty consistent. And again, no outcomes were reported on return to work or school with these therapies. Now I'm going to turn to the harms because we're interested in the net benefits, the benefits taking into account the harms. All three of the JAK inhibitors have black box warnings for serious infections, for the potential for lymphoma development, and a requirement to be tested for tuberculosis before initiating therapy because of the concern about reactivation of latent tuberculosis, and black box warning for all of them to continue to monitor for tuberculosis during treatment. Upadacitinib and baricitinib, in addition, have black box warnings for thromboses. These include venous thrombosis, DVTs, and PEs, as well as arterial thrombosis. The incidence of the serious adverse events in serious infections and so on are comparable across the JAK inhibitors and actually very similar to adalimumab, so not a big difference among any of them. To give some sense, in the randomized trials, the incidence of serious infections was pretty low and comparable to placebo, again, placebo being continuing on conventional DMARD therapy, of about 3 per 100 person year, so not a big uptick with the JAK inhibitors, and the thrombotic events happened in about 0.3 to 0.6 patients per 100 patient year, so about 0.5% per year for an individual patient, to give some sense of that. There are a number of controversies and uncertainties in this field. We don't have, as I alluded to earlier, we have no head-to-head therapies to compare the JAK inhibitors. And there's a lack of consistent reporting at 3 months, which is really the time point we think is most important. So that precluded indirect comparisons on most of the outcomes that we care about. Patients don't feel that the current patient-reported outcome tools fully capture the experience of patients with rheumatoid arthritis, so there needs to be ongoing work and development there, and that's challenging in evaluating the drugs when we don't have outcomes that patients say really captures their experience. The early crossover in all the trials limits any conclusions about long-term effectiveness of these therapies. And of course, immunomodulatory therapies potentially have long-term adverse events that we may not see for 10, 15, 20 years, so some uncertainty about adverse events over the long term. The ICER evidence ratings assigned to the therapies are all noted here. For upadacitinib and tofacitinib versus conventional DMARD therapy compared to continuing conventional DMARD therapy, there are clearly large improvements in all of the outcomes with no significant differences in adverse events. So we said there was high certainty of substantial net clinical benefit. For baricitinib in this same population, there are no randomized trial data, and there's no FDA indication for this patient population, so we gave that an I rating. In head-to-head trials for upadacitinib versus adalimumab, the trial results were statistically significant, smaller benefits, only one trial, not quite as much data, so we felt there was a moderate certainty of a small to substantial benefit, so a B+ rating. For tofacitinib versus adalimumab, they appeared very similar, so we gave it a C rating. Baricitinib versus adalimumab, we have no data, so an I rating. And then in the TIM-experienced populations, we had similar small trials with similar findings. They all appeared a little bit better than CDMARD therapy alone, but not substantially. So small and net benefit with potential substantial, so moderate certainty there again, because only single trials here and the trials were smaller than in the TIM-naive population. For other benefits and contextual considerations, certainly rapid return to function and work for patients and their caregivers is important, but it seemed comparable to other TIMs. The downstream clinical benefits are certainly reduced need for disability, joint replacement, and so on, but nothing really to distinguish them, at least with current data, from other TIMs and between each other. I alluded to this earlier, that one of the big advantages of the JAK inhibitors is that they're oral therapies, and for some patients that makes a big difference. In talking to patients and clinical experts, that varies from patient to patient. Some don't really mind coming in or doing sub-Q injections, but for some patients this is really, really important. And clearly, RA has a large impact on both length and quality of life, and it's essential that we have access to these therapies to prevent these deleterious effects of RA. We received a large number of public comments. I'm just pulling out a few that were thematic. I still don't have this down, sorry. We did rely predominantly on the randomized clinical trial data to inform the evidence base. That's an issue, in part because these therapies are newer therapies, so we don't have a lot of long-term clinical data. There were real-world data on the harms, and we did 2 new publications in the last couple of months, and those were included. Not a lot of head-to-head data of the JAK inhibitors and other TIMs in terms of clinical outcomes. Another important theme was the concern that we overly relied on the DAS28-CRP. I think in the clinical evidence section that's less important. I tried to present all the different outcome measures, but for our economic model we did use that. The reason this is potentially a concern, I think there are 2 concerns. One, patients overall seem to respond a little bit better by this measure than by other measures of disease activity, so it may be a little bit overly optimistic just in general compared to either the DAS28 ESR or the CDAI or the SDAI. The other thing is it incorporates CRP, and CRP levels are driven up by interleukin-6, IL-6, and we have some therapies that directly downregulate IL-6 levels. Tocilizumab, which was considered the last time as an anti-IL-6 therapy, and the JAK inhibitors also, through their pathways, directly downregulate IL-6. So a measure of DAS28-CRP may preferentially respond to JAK inhibitors and tocilizumab compared to, say, the TNF inhibitors like adalimumab. So that's a potential concern here. Again, important to look at the other measures of disease activity and the ACR response, which aren't subject to that bias. And finally, just highlighting that RA is a multi-system disease. We focus mainly on joints for our clinical outcomes, but there are many, many other disease systems that are impacted by rheumatoid arthritis, and not to forget that. And we've tried to highlight that as best we could, but it's a limitation of the evidence base. So in summary, the evidence base is accumulated over the last 20-plus years, documenting substantial benefits to TIMs over conventional DMARDs alone. The JAK inhibitors are comparable or superior to adalimumab in head-to-head trials, but there's greater uncertainty on long-term safety. And the evidence is really not adequate to distinguish JAK inhibitor effectiveness or safety amongst them. There are no head-to-head trials, and again, there were challenges with doing any kind of indirect comparisons other than the ACR data that I presented to you. With that, I'm going to change gears just briefly and talk about biosimilars. So this comes from the Biologics Price Competition and Innovation Act. It was passed in 2009. And the goal, as the title implies, is to increase competition and decrease costs for biologic therapy, which, as Steve pointed out, is a major cost driver for health and particularly for pharmaceuticals in this country. There are more than 20 biosimilars that have been approved by the FDA. But that's only had a modest impact on costs in the United States. It's had a larger impact in Europe, and hopefully during the policy roundtable, we'll try and tease out why that's the case. Biosimilars, by definition, must have the same mechanism of action of the reference product. They have to have the same route of administration, the same dosing. There is something called interchangeability, which allows substitution without a doctor's order. This is akin to you go to your pharmacy with a prescription that has a brand name for an antihypertensive medicine, and without saying it, calling the doctor, without telling you, they prescribe you the generic, even though the brand name is listed. So that's legal and sort of standard with generics in the U.S. For biosimilars, that is not the case. You have to go get another designation by the FDA, so-called interchangeability, and there really wasn't good guidance on how those studies had to be designed and the data, what data needed to be submitted to the FDA to get this designation until late this year. And so that's finally, those guidelines have been finalized now. I put no biosimilars yet designated. I'm wrong there. There's one. Dr. Murphy pointed out to me, which is one of the insulins has interchangeability status, but that's the only one so far. And that may play into part of the limited uptake in the U.S. Our example, and again, this was intended as an example for discussion, not an exhaustive review of all biosimilars or even all the data for Infliximab-dyyb. There's one trial, the Inflectra trial in the rheumatoid arthritis space. They randomized 606 patients to either Infliximab-dyyb or the reference drug Infliximab. The primary outcome was the ACR 20 at 30 weeks. It was approximately 61% responded by this definition if they were given Infliximab, randomized to Infliximab, versus 59% for the reference product. And they had similar outcomes for the other ACR measures, for the DAS28 measured using ESR and CRP, for the SDAI, CDAI, and they have multiple outcomes. The primary outcomes were at 30 weeks, but they also reported data at 52 weeks and 102 weeks, and the outcomes were similar for the therapies at all those time points, and there were no significant differences in adverse events at any time point. So with that, I can take a few questions, I think.
Well, maybe I'll go ahead, and if people have a question, please put up your name tag. You mentioned, I think, that the patients have not been happy with the PRO measurements. What is the issue, and what do you think is maybe, if there was the best measure, patient-reported outcome, any sense of what that would be?
I mean, I may want to defer to the patient representatives, but I think many of these measures don't fully capture fatigue and joint stiffness and things like that. There were some, particularly in Select Compare, the FACT-F measure looks at fatigue. They reported on joint stiffness. And so I think there are improvements in most of those outcomes, but across the randomized trial literature anyway, it's not been complete. And I think many people are promoting the PROMIS measures. Those haven't been consistently reported, but I will bow to the patient community here, the real experts.
Yeah, I think the difficulty with patient-reported outcomes in an exam room setting or in a clinical setting is that oftentimes the patient-reported outcomes, pain, fatigue, might not match those other disease activity standards, which can create a sense of disenfranchisement by the patient and difficulty in making a treatment change or other pieces there. So I think that's a big part of the focus. The other piece of it is not having those patient-reported outcomes captured in the study data. So you don't have that ability to compare your experience in an exam room to what happened in the clinical trial setting because it's not captured and you don't know what you should feel or shouldn't feel.
Can I share a little bit of my experience as well? So when I go to an exam, the follow-up exam, just a routine check with my doctor, I usually get a little questionnaire that asks about a variety of different tasks. Can you do these things with some range of difficulty level from no difficulty whatsoever to, I can't do it at all. Many of those tasks don't relate to the joints that are most affected by me in my body. So that's frustrating because I can walk as far as I want to. It's my hands that have trouble. So some of the questions are irrelevant. It also specifically asked me to think about in the last 7 days. Well, it's been 3 months since I saw my doctor last. If I've been great in the last week, but I know that I wasn't great over the whole last 3 months, it's frustrating to say, well, everything's fine right now because I feel like I'm lying because it really wasn't fine over the last 3 months, but that's not what the question's asking, so I have to answer the question on the paper. So that's a frustration. And there was one other thing I was going to say that I can't remember right now.
Well, I'll add to that.
We'll have time.
I think the other piece of the patient-reported outcome, to Peggy's point, is that patient-reported outcomes might be reported by patients, but if they weren't co-developed or co-produced by patients in the creation of the measure itself, you're going to have reports that are not reflective of the true experience of those 3 months and so on. And so I think that's a key consideration there. Thanks. So first, it's really helpful to have your perspectives, and I certainly hope we all take this as a real, call for when we're designing clinical trials to actually have patient-reported outcomes, because it's too easy, and certainly to the advantage of someone, and understandably, manufacturer wants to get the drug approved and on the market and start seeing profits and start distributing it if it works. But not having, meaningful outcomes and then getting drugs on the market that don't necessarily help patients to achieve their ends and still, are out there and expensive and causing side effects, which actually then brings me to my next question. So, as you know, it's common in the RCTs that the adverse events rate, for a lot of reasons, is lower than what we see when we use the drugs in practice. Are there any data from observational studies from the FDA database on what the actual adverse events rates have been for these drugs?
There are some, but they were not dissimilar from the randomized trials for serious infections. There are some infections that have been looked at in particular have been herpes zoster has been a relatively common, and the incidence didn't seem to increase over time or differ substantially from the randomized trial incidence data.
Thanks. And one more question. The last question was just on the biosimilar data, and you mentioned the slow uptake, and it does, I'll just share, when I worked for Senate Judiciary in 2004, we were working on biosimilars, and there was a lot of excitement about the potential to bring a lot of the newer drugs to patients, and it's been a very slow process and seems to have met a lot of resistance, and it's interesting to see the contrast, to drugs, recognizing that these are more complex molecules, but even, the name, tacking those 4 letters at the end, it seems like everything has been done to make it very difficult, very slow, very inaccessible, and this new criteria for interchangeable just makes me wonder, because the data you showed looked very good for the biosimilar, yet we know there was the famous, if anyone remembers that Synthroid case from 20 years ago that was at UCSF with the pharmacist who was actually prevented from publishing the data by the manufacturer because Synthroid generic performed as well as the brand name. And, in a lot of the talk about drug pricing, the EpiPen thing, it seemed like there's a lot of, the same manufacturer is making generic and brand name or making biosimilar. And so I'm just wondering what you see as the obstacles or things that we could address in the biosimilar market, and I'm sure we'll come back to it in the policy roundtable, but it's really relevant.
Yeah, I don't want to opine on that. I really focused on the data. I think there are many issues that go into it. I think that's more appropriate for the policy roundtable than here in the evidence section. So I'm going to defer the question. Sorry, I'll be a politician here.
You're not up for election.
Maybe one more quick question.
This is just about how long do patients typically stay on a JAK inhibitor? And how does the safety data compare to the duration of use? So if they're typically on it for 5 years, but we only have 1 year of safety data, or
I may defer that to the clinical experts in terms of, I don't know typically, what percentage of patients stay on for a year or 2 years or so on. But my sense is from the tofacitinib, which has been around, I think, the longest, that there hasn't been a significant increase in adverse events seen in years 2, 3, 4 compared to the first year. But maybe I'll defer to the experts on that.
I would agree. I'm unaware of any data showing increased adverse events with prolonged use. We've got more of that data with the other TIMs that have been on the market longer, and as a rule, we have not seen increased safety signals over time. And I guess we've got about, dating back to the initial clinical trials, about 25 years of data, starting with the TNF trials.
With regard to duration of therapy, there is no set fixed time after which a person would stop these medications. That's part of the concern about cost to the system, that when the drug price continues to go up, and this is drifting into policy roundtable, but the concern is that there is no end date that's set. It tends to be individually based, and we're just now getting better at understanding when patients may be able to taper or discontinue medication. That has not been a big focus of treatment in this area, and we're much better at getting people onto drug, treating to target, getting them to low disease activity and remission than we are recognizing that a patient might be a candidate for taper at this time.
Thank you.
Okay, at this point, we'll hear our next presentation on the economic model, and that'll be by Dr. Rick Chapman from ICER.
Thank you. So I'll present the results of the cost-effectiveness analysis from our assessment. I'd like to acknowledge our team member, Varun Kumar, who is the primary modeler on this analysis, is no longer at ICER, and we have no conflicts of interest to report. So the primary objective of this analysis was to estimate the cost-effectiveness of upadacitinib plus CD-MARD therapy versus adalimumab plus CD-MARD in TIM-naive patients with moderately to severely active rheumatoid arthritis. We originally wanted to look at other comparisons, especially of the JAK inhibitors to each other or to other treatments, but because of data gaps and limitations in the data, a lack of head-to-head data and lack of consistent outcomes data, as Dr. Tice reported, we were not able to do all of those comparisons. So our methods for the cost-effectiveness model, this was a new decision analytic model. It was partly based on the model we used for our 2017 RA assessment, but there were some notable changes from that earlier model. And so I'd like to point out that the results of this analysis are not directly comparable to those in our 2017 report. Our setting here was in the United States. We used a healthcare sector perspective, and our time horizon here was 1 year. And some of you who are used to our assessments may wonder why we're using 1 year rather than a lifetime horizon here. And there were several reasons for that. I think one of the main ones is that there really isn't a good guideline in terms of the treatment sequencing for these patients. And so often if these patients if the drug loses effectiveness over time, many of these patients are going on to other treatments, and it's not clear what those other treatments will be. There's no clear sequence there. So it presents a challenge for the modeling. One solution would be to try to model out those treatment sequences, but that then becomes a model looking at the cost effectiveness of a particular sequence rather than a particular drug. And with the number of potential sequences here, you rapidly get a thicket of choices to look at that would be impractical for this kind of a model. And the other problem, I think, is that once patients go on to those other treatments, those later line treatments, they may be on those for much longer than they're on the first line treatment. And the cost and effects of those later line treatments tend to swamp out what you see from the first line treatments. And so really to isolate the impact of those first line treatments, we went to a shorter time horizon, and in this case used a 1-year time horizon. We used a discount rate of 3% per year. It's not really relevant for our base case here. Our cycle length, this is one of the major differences from a prior model in our 2017 report, where we used a 6-month cycle length. Because we knew that treat-to-target approaches were often looking at patients at 3 months, their responses, we thought it was important to move to a 3-month cycle here. And our primary outcome is cost per quality-adjusted life year gained. We have cost per life year gained and cost per equal value life year gained in the model, but over a 1-year time horizon especially, there were very negligible effects on mortality, so we don't report those results here. So this is a schematic of the model. A cohort of patients comes into the model with rheumatoid arthritis. Those patients either get adalimumab plus CDMARD or upadacitinib plus CDMARD. At the end of the first 3 months, their disease activity is assessed using the DAS28. And for those patients in moderate to high disease activity, they discontinue treatment and go on to a second-line treatment. And I'll talk a little bit later about what's in that second-line treatment. For the patients who have remission or low disease activity, they continue on treatment and go into the further part of the model where we look at the initial HAC change from that movement into remission or low disease activity. And we also look at the trajectory of the HAC over time. So we look at how their function may change over time as they proceed through the model. And there's also a chance that patients will switch to other treatments over time. And that discontinuation rate was based on data from a patient registry in RA patients called Corona. The HAC change and HAC trajectory further influence the outcomes you see on the right side here. The utility is tied to the change in HAC over time. Mortality is related to the HAC score, and the chance of hospitalization and number of hospitalization days is related to the HAC score. This is the characteristics of the target population that entered the model. These are all adults with moderately to severely active RA with inadequate response to CDMARDs, and they were naive to TIM therapy. And you can see the characteristics of the patients here. This is from the Select Compare trial. Mean duration of disease was 8 years for these patients. And the treatment strategy we're looking at, as I mentioned before, is upadacitinib plus CDMARD versus adalimumab plus CDMARD. There were several assumptions we had to make as we did this modeling. One of these was how to map the DAS28 into HAC score. We had EULAR to HAC mapping algorithm that was in the literature and had been used in our prior report, but we could not find any robust mapping from the DAS28 into either HAC or directly into utility scores. So we made an assumption here that the DAS28 disease activity categories could be mapped into EULAR response categories. And our assumption was that remission on the DAS28 equals good response on the EULAR scale, low disease activity equals moderate response, and patients with moderate and high disease activity go into the no response category for EULAR. I mentioned before that patients, once they discontinue, go on to a second line and further. And for the second line and lines beyond that of treatment, we used a market basket approach and used an average of the effectiveness of the treatments seen here: baricitinib, adalimumab, etanercept, tofacitinib, golimumab, and upadacitinib. Further, we knew from the literature that patients often have reduced effectiveness when they go on to second TIM, and so we used an estimate from the literature that there was a 16% reduction in effectiveness and applied that here So the average efficacy in the second-line treatments is 84% of the calculated average efficacy. And I'll point out that we only applied that 84% reduction once. So if patients discontinued their second-line therapy and went on to a third line, they didn't get another 84% decrement. Here are the key model inputs in terms of treatment response at 3 months. This is looking at the proportion of patients achieving different categories of disease activity using the DAS28. And you can see for upadacitinib, you get more patients in remission category than for adalimumab and fewer patients in the moderate and high disease activity categories. And then I also present here the second-line market basket. You can see here the 22% in remission, 14% with low disease activity, and 64% with moderate high disease activity. And this is prior to applying the 84% decrement that I talked about before. Another key model input was the utilities that patients achieved from these treatments. As in our prior model, we used a relationship between the HAQ score and utility that came from a study by Wailu et al. And this mapped HAQ into utility scores using the EQ5D and U.S. patient-based tariffs for that. The EQ5D score was calculated by using an equation that you can find in our report, and it relates the patient's age and sex, the duration of disease, the number of previous DMARDs they had tried, and importantly, the baseline HAQ and the current HAQ. And those all feed into calculating the utility score for a patient. So as their HAQ improves, their utility score improves. And we also included a disutility in the model for 1 month for patients who had a serious infection. Here are the costs of the different drugs that go into the model. You can see the WAC cost here. Adalimumab is higher than upadacitinib, but when you apply discounts, the discount we saw in the SSR Health database was about 34% for adalimumab. That brings the price down to about $44,000 per year. For upadacitinib, because it's relatively new to market, we didn't have net price data yet. So we used an average of the discounts for the other 2 JAK inhibitors who have been on the market, which came out to 26%. And when we apply this to the list price of upadacitinib, you get an annual net price of $44,000, very close to the price of adalimumab. And you see here the price for methotrexate sodium, which is what we used as the CDMARD in the model, is much lower. This is the average generic cost for methotrexate. And I should mention the model also has cost for hospitalization, which are related to HAQ-DI score. So now moving on to the results of our analysis. See here the base case results for upadacitinib versus adalimumab. The total cost, you can see, are slightly higher for upadacitinib over adalimumab, and I'll remind you again, this is over a 1-year time horizon. And you can see over the 1-year time horizon, as mentioned, the mortality effects are negligible, so no change in life years. But in QALYs, we do see some increase in QALYs from those larger number of patients being in the low disease category or remission categories prior to the 1 year. And that's reflected when you look at the last column there, which shows the months in remission on line 1 therapy. You're getting about 2.8 months with upadacitinib and 1.7 months with adalimumab. When you look at the incremental cost and incremental effectiveness for these 2 treatments, you get an incremental cost per QALY for upadacitinib versus adalimumab of $92,000 per QALY. And if you look at the cost per months in remission, it's about $600 additional cost. We did sensitivity analyses on the base case results. In one-way sensitivity analyses, the only major driver of results was the cost of the second-line TIM market basket, which again I think shows the influence of that second-line treatment once patients go on to that. Other factors that we looked at had much smaller impacts on the outcomes. And then in probabilistic sensitivity analyses where we varied all of the variables and reran the model several times, we found that in 26% of simulations, upadacitinib compared to adalimumab would be cost-effective at $50,000 per QALY. If you look at $100,000 per QALY, it's a little over half, which I think is reflected when you think about the base case results, which were around $92,000, so just under $100,000 per QALY. And then when you look at, if you increase the threshold to $150,000 per QALY, you get 80% of the simulation. So it looks very likely that it would be cost effective at $150,000 per QALY. There were several limitations to this model, as with all cost effectiveness models. As I mentioned before, treatment sequencing isn't standardized, so it made it difficult to isolate the effect of the initial TIM therapies over a lifetime horizon, so we went to a 1-year horizon. We were unable to directly compare upadacitinib and the other JAK inhibitors due to a lack of published data, and we had to use the same discontinuation rate for TIMs and CDMARDs due to no robust long-term published data for all of these treatments. And then finally, disease activity as measured using DAS28 was mapped to EULAR response categories in the absence of a validated mapping algorithm from DAS28 directly to HAC or directly to utility scores. We received several comments, public comments on the model. These are some of the major ones or most frequent ones. Several people urged us to go to a lifetime horizon rather than 1 year, as our standard is. And I think I've discussed our reasons for using the 1-year horizon. We also had several comments about the DAS28 to EULAR to HAC crosswalk, that was not validated. We acknowledge that it's not yet a validated crosswalk, but we had we're not aware of any other ways to translate DAS28 into HAC or utility scores. We had comments about we should be using the DAS28 ESR rather than the CRP measure because of JAK inhibitors' impact on the CRP due to its unique mechanism of action. And I think Jeff, Dr. Tice has discussed that as part of his report. And then finally, we had people urging us to provide a disclaimer around the differences from our previous report to reduce the risk of misinterpretation by decision makers. And we have added some explicit text to the report stating that these results should not be directly compared to the prior report because of the differences in the modeling here. So in conclusion, we think that upadacitinib provided marginal clinical benefit over adalimumab at higher cost, but that results in incremental cost-effectiveness ratios that fall below commonly cited thresholds of $100,000 to $150,000 per QALY. And importantly, we think more comparable data are required on the short and long-term efficacy of the JAK inhibitors and other treatments to allow for more direct comparisons among them. And I'll take questions now. Thanks.
Go ahead. Yes. Questions?
Go ahead.
So I was just wondering why you didn't use the QALY data collected in the trials. And then I had a second question.
Yeah, we had a hard time with some of these comparisons because when we first started out, we really wanted to look at all of these treatments relative to each other. And in many cases, we didn't have complete data for some of these measures. And at the time, one of the things we were missing was good quality data for all of these treatments.
And then, if I understood you right, the strategy you used could be considered an optimistic estimate of the extra quality-adjusted life years that patients get from the new product.
To the extent that the DAS-CRP may be overestimating the effectiveness or biasing the effectiveness in some way, it may be favoring the JAK inhibitors. Yes.
Oh, go ahead.
So I wanted to go back to the slide on the base case scenario, and I was a little bit struck by how similar the QALYs were between the comparison and how different the months in remission were. It seems like those two things should be fairly correlated. So if you could explore that, why those are so different.
Yeah, I think there is a correlation there. It may not show up as clearly here because, for one thing, this is months in remission, whereas the qualities are related to remission, low disease activity, and moderate high disease activity. So we don't see that intermediate category in here. And also, this is over a 1-year time frame. So quality difference of 0.006 over a 1-year time frame, I think is actually a fairly sizable increase in qualities.
Oh, thank you. I had a question about how sensitive it was to infection rates, because it seemed like, given your disutility, you applied for an infection rate that would sort of was negative 0.15 utilities or something that would overwhelm the quality benefit if it was, I think it came out to like 1 in 26 infection rate. So, it seems like if it's 1 versus 2 out of 26 patients getting a significant infection, that could definitely change your conclusion. So is there enough data, do you say, to have confidence around the infection rates?
Well, I think there is uncertainty around the infection rates. I think there's also uncertainty around, what kind of range, plausible range we should put around our point estimate there. So it's certainly possible that we didn't have a wide enough range in terms of what we were estimating there. But I think probably also, again, using a 1-year time frame, there's not as much chance for multiple infections to occur. And I'll just also mention that the utility decrement there was for 1 month, but it's only for 1 month out of the year. So,
any other questions in the panel? All right. Well, then, thank you. And at this point, we'll move on to public comment. And we have one person who's going to give public comment. We'll have them come up to our main table here. That's Amanda Grimm-Wiegroth from the American College of Rheumatology. And again, before giving your comments, please announce any conflicts of interest.
Good morning. My name is Amanda Grimm-Wiegroth, and I serve as the Regulatory Affairs Director for the American College of Rheumatology. I have no conflicts to report. ACR appreciates the opportunity to provide comments during this hearing, and we applaud ICER's work on the cost and value of treatments for rheumatoid arthritis. We have long supported comparative effectiveness research, as we believe this research allows patients and providers to be more informed about the value of diagnostic and therapeutic options. As the healthcare landscape continues to move toward the value proposition, comparative effectiveness research is an important tool in highlighting value for therapeutics. We appreciate ICER's detailed review of the private payers' use of utilization management and how these methods can negatively impact rheumatoid arthritis disease activity. We strongly encourage ICER to note when these utilization management tools counter FDA approval, specifically when the step therapy requirements are more stringent than the FDA indication, ACR clinical guidelines, and/or established clinical best practices. The report highlights the step therapy requirements for TNF antagonists prior to access to the JAK inhibitor. This step therapy requirement prioritizes the rebate status over the clinical appropriateness of the treatments. These step therapy requirements increase the overall cost of managing the disease, as providers are forced to first prescribe a therapy or therapies that they know will be less effective for their patients. Patients are required to suffer with the less effective therapy and will be required to see their physician more frequently to satisfy the step therapy requirements prior to gaining access to a more effective therapy. As ICER continues to review the cost and value of treatments, we strongly encourage this group to provide more emphasis on biosimilars. While we note that the report mentions biosimilars, we believe that the potential impact on the overall cost and value to the healthcare system was minimized. Medicare payment data shows that the impact of biosimilars have had on reducing the cost of Infliximab, a life-changing therapy for our patients. In contrast, we see that the prices of biological, innovative products without competition from biosimilars continue to rise. We strongly encourage this group to provide more focus on the role of biosimilars as a way to maximize value and control costs in the healthcare space. We do fear that reports such as this one will actually lead to an increasing barrier to patients to have access to care when insurers simply focus on a reported dollar amount in cost for value and use that to deny coverage for a treatment that may be a certain patient's best option or last option. The drug pricing arena is complicated. Due to the reverse rebate incentives in the PBM space, lowering drug prices is not as simple as pointing out an excessive cost and expecting the manufacturer to cut their list price. We encourage ICER to emphasize this dysfunctional dynamic of drug pricing and to aggressively foster discussion regarding potential solutions. We encourage ICER to understand and highlight how step therapy protocols are based on rebates rather than evidence-based treatment approaches. We appreciate the opportunity to be part of this hearing, and we look forward to working with you in the future.
Thank you. And at this point, we'll have a comment from the manufacturer. We believe we have Mark Jensen. Welcome to come up to our table. And again, please provide any potential conflicts of interest.
Hello, my name is Mark Jensen. I'm with the Medical Affairs Group at Pfizer, and I would like to make one statement to Dr. Tice's slides, and that is that there is a black box warning for thrombosis for tofacitinib as well, right? I just want to clarify that as well. So I am, my job is really to work with healthcare professionals and physicians, rheumatologists, to provide them data on tofacitinib and our JAK inhibitor profile. My knowledge of some of the models used for pharmacoeconomic studies is pretty limited, but I do have a lifeline. If there are any questions about that part of the methodology, I'll be happy to answer those. So with all due respect, thank you for the opportunity for Pfizer to provide feedback today to the panel. In this public comment, we would like to emphasize that the medical value of Xeljanz has been demonstrated by numerous Phase 3 and Phase 4 clinical trials, as well as real-world evidence collected during the 7 years that Xeljanz has been prescribed to more than 280,000 patients around the world. We'd also like to clarify some confusion that certain misleading public statements and the evidence report by ICER may have created. In our public response to ICER, we have repeatedly commented on the methodological flaws in the cost-effectiveness model used and inconsistencies in interpretations drawn by ICER from the model results, as emphasized also by other stakeholders like IVI. We remain concerned that ICER has not addressed these issues in the updated report. Pfizer would like to point out that the decision to use DAS28-CRP at 3 months as the primary endpoint in the cost-effectiveness model creates risk of substantial bias and uncertainty in the results presented to you today, as many RA trials have not calculated this endpoint. The primary endpoint in the vast majority of RA clinical trials is the ACR20 response rate, as it is used for U.S. regulatory submission and approval. The current new model choice made by ICER implied the need to make substantial assumptions not supported by the literature and the inability to compare tofacitinib to adalimumab in the cost-effectiveness model. ICER's conclusion that there are not sufficient data to compare tofacitinib to adalimumab is not correct as demonstrated by the peer-reviewed published cost-effectiveness models that are comparing tofacitinib to adalimumab. Moreover, there is a wealth of published data on tofacitinib, including several studies with direct comparisons to adalimumab, just not for the particular time point ICER selected to assess efficacy. Beyond these issues with the cost-effectiveness model, what we'd really like to emphasize today is the wealth of data supporting the medical value of tofacitinib, which was approved in the U.S. in 2012 as the first oral JAK inhibitor to treat rheumatoid arthritis. ICER did highlight this in their report. Tofacitinib has been studied in over 50 clinical trials, totaling 36,000 patient years to date. ICER rated the quality of clinical trial evidence for tofacitinib compared to conventional synthetic DMARDs as having high certainty of an incremental net benefit ranging to superiority, depending on the trial and population. ICER also rated the clinical trial evidence comparing tofacitinib and adalimumab, demonstrating that they are comparable in net health benefit. The ICER results, with regard to clinical effectiveness are aligned with results published in peer-reviewed journals. While there are no head-to-head data directly comparing tofacitinib and upadacitinib, AbbVie recently published a matching-adjusted indirect comparison of tofacitinib and upadacitinib. Once those results are adjusted for multiplicity, there is no significant difference between ACR 20, 50, and 70 response rates at 3 months, and there's also no significant differences between products in the SDI clinical remission, CDI clinical remission, or DAS28 CRP remission at 6 months. Beyond these clinical trial data, tofacitinib has also been widely studied in real-world setting. These data were not covered fully in the ICER report. In partnership with the Corona Registry, several real-world studies have looked at the safety and effectiveness of tofacitinib in patients with RA. These results demonstrate that the efficacy and safety seen in the clinical trial program are consistent in the real-world setting. Given that tofacitinib has been prescribed longest of the JAK inhibitors and has been used in over 280,000 patients worldwide, it is the only JAK inhibitor that can demonstrate robust real-world effectiveness and true impact on patients outside of the highly controlled clinical trial setting. This is very important if we would like to take a patient-centric perspective. Thus, we urge the panel to look beyond the inconsistent conclusions drawn by ICER in their summary and focus on ICER's rating of evidence as you weigh the relative benefits of the products today. Many patients have benefited from treatment with tofacitinib in both the clinical and real-world setting. The flawed methodology, looking only at the small fraction of evidence supporting the medical value of tofacitinib, led to a biased, unobjective view of the full value of tofacitinib and its importance as a treatment option for appropriate patients suffering from this devastating disease. With that, I'll take any questions.
Thank you. I think the panel will get a chance to ask questions in a moment of both industry as well as our prior speaker. But first, I'd like to ask if ICER, either Dr. Chapman or Dr. Tice, have comments or responses.
Sure, thanks. It was difficult to come up with an outcome for this model. There are so many different outcomes that are out there in trials, and there's a lot of inconsistency over time in what outcomes have been measured. In our last assessment, we did look more at ACR results. We heard at that time that there were a lot of shortcomings of using those measures. And one of the reasons we switched to the DAS28 CRP was also because of the 3-month time point measurement, which we had heard from various stakeholders was becoming more and more important in assessing these types of treatments.
I just want to echo that. I mean, I think the current paradigm from clinical experts, and you can respond to this, is to assess treatment response at 3 months, and if you don't achieve adequate treatment response, to change. So 3-month outcomes were key. You do have 3-month outcomes because you've published pooled data. We specifically asked for the 3-month treatment response data and never received the data for the specific clinical trials. We actually, I think, if we were able to get those data, would have actually probably switched to SDI as the primary measure of treatment response, and potentially would have been able to model this. But the lack of 3-month data provided to us, even though it was clearly available from the clinical trials, limited both the clinical review and, most importantly, the economic analysis. I think the clinical conclusions were in agreement with what you said, superior to, in the TIM-naive, superior to continued CDMARD therapy, no question, and appears to be similar to adalimumab. In the 2 head-to-head trials, the conclusion were both that there were similar treatment outcomes. So, we were, really would love to continue to work with you, because undoubtedly this will come up again, to actually include the 3-month outcomes from your trials in order to perform a better model, probably with a different measure of treatment response than DAS28 CRP.
May I comment on that? I think that reflects the fact that tofacitinib trials were started back in 2009. So we're looking at quite a bit of time difference. And I think when the treat-to-target paradigm was being created about that time, there was still talk about 3 to 6 months being an adequate time to assess disease activity. And I'll leave that up to my rheumatology.
Yeah, no, agree 100%. We understand that historically the standards were different, and that's why 6 months was more of a typical response. But you've published on 3-month data in pooling all of your trials, but you haven't made the individual trial data available, which would be very helpful to have the 3-month outcomes that you do have available to us in the future.
Noted.
Let's see, any questions from the panel?
Hi. One of the things that I think Jeff or somebody mentioned, but we haven't talked about in much detail, is the specificity of these 3 JAK inhibitors, which all seems to be different. So I'm wondering, for our clinical experts, it sounds like we don't have definitive data if that makes a difference, but what are the theories? What do people think about that?
So there are 4, I believe, different JAK targets. There's JAK 1, 2, 3, and TIC. I'm not a basic science person, but these drugs do all have slightly different specificities, which, at least in theory, are supposed to make certain ones more or less prone towards cytopenias or other side effects. I'm not sure in clinical practice whether that has really panned out to show a meaningful difference in any sort of toxicity or efficacy profiles.
Yeah, I think it's important to distinguish the hope of JAK selectivity versus the data that we have thus far that demonstrate, even in clinical trials, we're just now determining whether the promise of selectivity has been delivered to patients. So at this point, I'd be very reluctant to believe the in vitro modeling of the data. It may prove to be true. At this point, we don't have enough data to demonstrate that theoretical advantage has translated into a meaningful difference.
Thank you. At this point, actually, we'd like to have a brief comment from another speaker, Kristen Griffing, and please let us know if you have any potential conflicts of interest.
Thank you for the opportunity. My name is Kirsten Griffing. I am an employee of Eli Lilly and Company. Eli Lilly has not prepared a formal comment or response, but I would like to clarify some of the material that was presented in Dr. Tice's presentation. The comment was made that RCT data for baricitinib 2 milligram in the conventional DMARD inadequate response population do not exist, which is not accurate. The RA Build program did study baricitinib 2 milligrams as well as 4 milligrams versus placebo in a methotrexate inadequate response population. However, I recognize that this does not change the discussion of the model because the conventional synthetic DMARD inadequate response population is not the indicated population for baricitinib 2 milligrams in the U.S.
Thank you. Any response from ICER?
I stand corrected. I'm sorry, I misspoke there. That's absolutely, was the fact that the 2 milligram is not doesn't carry an indication for this. I'm sorry. Thank you.
Correct. And that population continues to be an area of discussion for us.
And any questions, I think, from the panel or our clinical experts or patient representatives? Okay.